Malignant cardiac tamponade in a patient with lung adenocarcinoma, presented by Angia Aswani, Dr. Aguilar Guerrero, Dr. E. Madera, Dr. O. Aquino Arango. A brief introduction. Major causes of pericardial effusion include infection, malignancy, heart failure, renal failure, liver cirrhosis, autoimmune disease, Dressler syndrome, and medications. Metastatic pericardial effusions are more common than primary pericardial neoplasm. The most common causes of malignant pericardial effusions are lung and breast cancer. Pericardial effusions in the setting of lung cancer is associated with poor outcomes as it is a marker of advanced disease, with up to 60% of the patients developing cardiac tamponade. Treatment of recurrent pericardial effusion is often challenging, especially when complete remission of the underlying cause is not possible. Pericardiocentesis is the standard treatment for acute management of symptomatic and/or hemodynamically significant pericardial effusion. Malignancy is an immunocompromised state. A pericardial window is a promising and effective management option for patients having recurrent malignant pericardial effusion, but it comes at the cost of complications such as bleeding and infection. It is essential to include malignancy as part of the differential diagnoses in the setting of rapidly accumulating or recurrent pericardial effusion. Case presentation: 74-year-old female with a medical history of non-Hodgkin lymphoma, left lung adenocarcinoma, rheumatoid arthritis, hypertension, and diabetes mellitus, presented to the emergency department due to worsening shortness of breath, altered mental status, nausea, and vomiting. 3 weeks prior to admission, she had undergone a thoracentesis due to recurrent left pleural effusion with positive cytology. Clinical presentation included shortness of breath, and initial vital signs were blood pressure 130/76, pulse 117 beats per minute, respiratory rate 30 breaths per minute, temperature 36.7 degrees Celsius, and saturating 92% on room air. Labs were significant for moderate leukocytosis, and chest x-ray showed left pleural effusion. Malignant left pleural effusion is suspected. Repeat thoracentesis performed with initial improvement of her dyspnea and tachycardia. As seen in Figure 1, pleural effusion fluid obtained after therapeutic thoracentesis. Macro and microscopic characteristics of pericardial fluid wave were similar. Due to persistent dyspnea, transthoracic echocardiogram is ordered, showing ejection fraction 55% to 60% with large free-flowing pericardial effusion, as seen in Figure 2. Maximum measurement was 2.8 centimeters. As we can see in the echo, large free-flowing pericardial effusion with right ventricle inflow variation. Due to enlarging pericardial effusion and clinical development of cardiac tamponade, cardiothoracic surgery service was consulted. Pericardial window performed and left chest tube placed. Pleural and pericardial fluid was positive for malignancy, and diagnosis of malignant pericardial and pleural effusion was made. In conclusion, primary tumors of the pericardium are infrequent, and most are secondary and result from metastasis from lung and breast cancer, malignant melanoma, lymphomas, and leukemia. A high level of awareness in patients with cancer can lead to an early diagnostic and intervention. Combination of cytology, pericardial, and epicardial biopsy will give the best diagnostic yield. Urgent drainage may be required, especially in patients with cardiac tamponade. Pericardial fluid removal can be performed via pericardiocentesis or via surgical pericardial window. Other possible therapies include anti-neoplastic systemic agents, extensive catheter drainage, or radiation. Thank you so much for your time.